To tackle this massive amount of clinical data, we're breaking things down into 4 clear-cut categories: congenital anomalies, vascular emergencies, infectious abscesses, and herniation syndromes. So let's jump right in. Section 1. Congenital anomalies, focusing on neural tube defects and malformations. We are starting at the very beginning of the patient life cycle here. Right off the bat, there's a stark clinical divide when we talk about neural tube defects. Think of spina bifida occulta as the hidden one. It's a closed, mostly asymptomatic vertebral defect. Honestly, a patient might go their whole life without knowing they have it, maybe just noticing a telltale tuft of hair over their lower back, because there's zero herniation of the meninges. But then you have spina bifida aperta. This is an open defect. The meninges and sometimes the spinal cord itself are actually herniating externally. And as you'd expect, that leads to serious clinical signs, like lower limb weakness and major bowel or bladder dysfunction. Now, we all know folate deficiency is a major risk factor here, but pharmacology plays a huge role too. High-risk drugs, specifically certain anti-epileptics like valproate and phenobarbital, really crank up that risk. If a baby is born with an open defect that's leaking cerebrospinal fluid, immediate emergency surgical repair is an absolute must. But what's truly mind-blowing about modern medicine is that fetal surgery, literally repairing these defects in utero before the baby is even born, is now the treatment of choice. It's an absolute game changer for the child's prognosis. Moving up the neuroaxis to the base of the skull, we have the Chiari malformations. The contrast here is huge. Chiari 1 is defined by the cerebellar tonsils dropping more than 5 millimeters into the cervical canal. It's super sneaky. It often stays completely hidden until adulthood, when it finally shows up as neck pain. Chiari 2, total opposite. It strikes hard in infancy. You've got the displacement of the vermis, the medulla, and the fourth ventricle. This causes a severe, progressive hydrocephalus that demands immediate intervention. To cap off congenital issues, let's talk about Dandy Walker. This is actually the most common posterior fossa malformation. Picture a massive, fluid-filled cystic dilation of the fourth ventricle. It's essentially acting like a balloon, pushing everything outward and upward. Because of all that trapped fluid, the most obvious clinical sign is macrocephaly, a noticeably enlarged head. The game plan here is straightforward. Surgically correct that hydrocephalus to get the pressure down. Section 2. Vascular emergencies, specifically looking at aneurysms and subarachnoid hemorrhages. Let's pivot to a world where neurosurgery becomes an immediate race against the clock. If a patient ever says this exact phrase to you, stop everything. The worst headache of my life. When a berry aneurysm ruptures and causes a subarachnoid hemorrhage, this is universally how patients describe it. It's not just a bad migraine. It's a sudden, explosive thunderclap headache. It's a massive red flag. So where do these things actually hide? Well, these saccular, berry-like aneurysms love the circle of Willis at the base of the brain. Statistically speaking, they most frequently form and rupture right at the apex of the junction between the anterior communicating and anterior cerebral arteries. Think about the intense, constant hemodynamic stress at that vascular fork. It's practically the perfect storm for an aneurysm to balloon out. When that rupture actually happens, your go-to investigation is a non-contrast CT scan. We use the Fisher grading scale to rapidly classify the bleeding based on the thickness and location of the blood layers. But, and this is a big but, what if that CT scan is totally clear, yet your clinical suspicion is still screaming subarachnoid hemorrhage? You go for a spinal tap. If you draw cerebral spinal fluid and it has this yellowish tint, what we call xanthochromic fluid, boom, you've confirmed the diagnosis, even if the CT missed it. Once you've got your diagnosis, you have to grade the clinical severity to figure out prognosis and surgery. There are 2 main scales, Hunt and Hess and the World Federation of Neurosurgical Societies, or WFNS. Notice how the WFNS scale is way more objective? That's because it relies strictly on the patient's Glasgow Coma Scale score and motor deficits. It completely removes the guesswork of subjective symptoms like mild headache versus lethargy. Now, you might think the danger is over after the neurosurgeon successfully clips or coils the aneurysm on day 0. Actually, scratch that. The absolute most dreaded complication is a delayed ischemic neurological deficit. This happens because the blood vessels in the brain start spasming as a reaction to that initial blood. This terrifying risk window opens around day 2, peaks right at day 6, and finally tapers off by day 10. A patient could be sitting up, awake, and talking to you on day 1, and completely deteriorate on day 3 because a spasm just reversed their whole recovery. Rigorous monitoring during this window is literally life or death. Section 3.
infectious pathologies focusing on brain abscesses. Time to shift gears from sudden vascular ruptures to these stealthy infectious pathologies.
The location of a brain abscess isn't just random chance. The origin of the infection usually dictates where it ends up. For example, a blood-borne hematogenous infection typically seeds in the parietal lobe. But local spread is much more direct. A severe frontal sinus infection, that's predictably going to punch straight back into the frontal lobe. An unresolved ear infection or otitis media, that's breaching upwards right into the temporal lobe. Once an MRI reveals that classic glowing ring-enhancing lesion, your management pathway is incredibly rigid. You only go in surgically to drain it if it's a solitary symptomatic abscess. If that MRI lights up with multiple small abscesses scattered everywhere, surgery is off the table. You rely entirely on a massive, continuous, 6-week course of IV antibiotics. And a quick clinical pearl, you only add steroids if the intracranial pressure is dangerously high. Otherwise, let the antibiotics do their job. Section 4, Structural Emergencies, diving into brain herniation syndromes. Finally, we reach the explosive crescendo of neurosurgery. This is the sheer, devastating physics of what happens when massive intracranial pressure forces the soft brain tissue to physically shift and crush against the rigid skull. Let's start with uncal herniation. Imagine a mass in the temporal lobe expanding. It forces the inner part of that lobe, the uncus, straight downward through the cerebellar tentorium. As it squeezes through, it crushes the third cranial nerve right next to it. This gives us an early, highly recognizable sign, a dilated or blown pupil on the exact same side as the mass. As the brainstem takes more of a beating, you get a late sign, weakness or hemiparesis on the opposite side of the body. But here's where neuroanatomy kind of plays a trick on us. It's called Kernahan's notch phenomenon. It's a classic false localizing sign. The herniation pushes the brainstem so incredibly hard that the motor tracts get crushed against the opposite edge of the skull. Since those tracts eventually cross over, the body weakness actually shows up on the same side as the original brain lesion. This can deeply confuse your clinical picture. If you see right-sided weakness, you'd normally assume a left-sided brain problem. But with this phenomenon, the mass is actually on the right. And the mechanical damage doesn't stop there. This immense downward pressure does catastrophic things to the blood supply. It physically stretches the tiny, delicate perforating arteries feeding the brainstem until they literally snap. This results in direct hemorrhages, fatal bleeding right inside the ventral brainstem. Once this happens, the damage is almost always irreversible. The mechanics of the other herniation types are equally devastating. A frontal mass causes a subfalx sign shift, shoving brain tissue right under the rigid falx cerebri. That can pinch off the anterior cerebral artery, causing a massive stroke. Then you have central or cerebellar herniations, which push the brainstem straight down to the foramen magnum at the base of the skull. That directly crushes the medullary respiratory centers, leading to rapid respiratory paralysis and death. We have sprinted through a staggering amount of high-yield neurosurgery today, from marveling at neural tube repairs in the womb to catching that terrifying window of vasospasms to the pure destructive physics of brain herniations. But seeing how fast increased intracranial tension turns into a fatal mechanical shift leaves us with one incredibly provocative thought to end on. As imaging gets faster and monitoring gets more precise, how can modern medicine continue to out-innovate and completely prevent the devastating physics of brain herniations before they even begin? Thanks for joining me on this explainer. Keep asking questions, and I'll see you next time.